Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Iman Baroum, consultant radiologist. I'm moderating the breast session for this afternoon. Today we have 4 speakers who are going to present their experience in breast cancer screening and to share ideas. Our first speaker is Dr. Samira Balgasim Sulaimani. She is consultant radiologist at King Fahad General Hospital in Medina. She's dedicated for breast imaging since 2010, and she is the supervisor of breast cancer screening in طيبة Center, Cancer Screening Center in Medina region. She is RSNA and ECR member. Dr. Samira, she's going to present us breast cancer screening in Medina region. Dr. Samira.
Bismillah ar-Rahman ar-Rahim. It is my pleasure today to give you some hints about our screening program in Al-Medina region during the last 4 years. I will talk about total population in Al-Medina al-Munawwara. I will give you a hints about طيبة Screening Center, our strategy in fighting against breast cancer, our documented statistics, and our future mission. As we all know that breast cancer is the most common cancer in women, and it is the second leading cause of death. 1 million women develop breast cancer each year, and early detection and treatment is the most promising approach to reduce breast cancer mortality. Screening in a definition is the examination that performed regularly among asymptomatic ladies to detect clinically occult breast cancer at an early stage. According to the WHO definition of screening, it is the test which must be accurately sensitive and specific. It should be reproducible in its results, and it is to identify previously undiagnosed disease. It should be affordable, and it have to be acceptable to the population, and it should include follow-up services. As last estimation, the Saudi population is around 28.7 million, including about 7.5 non-nationals. Al-Medina al-Munawwara total population is 1.9 million. It is in the third position of the King Saudi Arabia population. Male to female ratio is 46% is ladies and 54% is male. Average age group. Actually, in our screening program, we are targeting ladies over than 35-year-old in their age, and our targeted group from 35 to 60-year-old is about 22%, and those over 60-year-old is about 13%. So our targeted group in Al-Medina al-Munawwara is 323,000 ladies. Total number of hospitals and the clinic in Al-Medina Munawwara, MOH hospital is about 12, non-MOH governmental hospital is 2, private hospitals is 10, MOH polyclinic is 171, private polyclinic is 14. Actually, طيبة Screening Center is established in 2009, under Saudi Cancer Society umbrella, and it is the first screening center in المدينة المنورة providing cancer screening of breast, prostate, cervical, colon. It also screen for osteoporosis. It is equipped by 2 fixed full digital mammography, 1 mobile track, and 1 ultrasound. Our strategy in fighting against breast cancer, actually we are depending on the primary health care as a main referral centers, and those ladies referred from the primary health care come to the mobile track or to طيبة screening centers, or they can come independently. There, the general practitioner will examine the lady's breast, and the technologist will perform the mammogram at the same day. The collected mammogram images are evaluated weekly by 2 radiology consultants in a double-blind reading. And the reporting result either negative or positive. If it is negative, it will go for routine screening. If it is positive, it will go for further evaluation at King Fahd Hospital. Our documented statistic. In 2009, we did about 700 mammogram cases, and the recorded cases was about 160. In 2010, we did about 1,000 cases, and the recalled patient was about 186. In 2011, we did about 1,800 cases, and 258 were recalled. In 2012, we did about 3,637 cases, and 350 cases were recalled. In 2009, we sent 15 cases for biopsy, 6 of them were positive. In 2010, we sent 28 ladies for biopsy, and 15 of them were positive. In 2011, we sent 48 patients for biopsy, and 34 of them were positive. In 2012, we sent 70 cases for biopsy, and 53 of them were positive. By the end of December 2012, our targeted number from the beginning was 323,000 ladies, and the actual screened ladies during the last 4 years is 6,441 lady. This means we screen about 2% of our targeted group. And among those screened ladies, we discover 108 cases to be positive. This means 1.68% were positive. Our mission for the future is to cover our targeted group and to cooperate with other screening centers in the Kingdom to introduce successful national screening program. Thanks to all.
Our next speaker is Professor Fatma Al-Milham. She's going to talk about the Eastern Province experience in early breast cancer detection. Professor Fatma, she's consultant radiologist, College of Medicine, Dammam University. She's the chairperson of radiology department at King Fahd Hospital of the university. And she's the chairperson of Breast Cancer Early Diagnosis Committee, Saudi Cancer Foundation. Dr. Fatma?
Thank you. Assalamu alaikum. I would like to thank the organizing committee for their kind invitation. I'll present our experience in the Eastern Province of Saudi Arabia in early detection of breast cancer. And this is under the umbrella of Saudi Cancer Foundation. We all know that breast cancer is a global issue. Breast cancer is the most common cancer in women worldwide. It is also the principal cause of death from cancer among women globally. Despite the high incidence rate in Western countries, around 89% of women diagnosed with breast cancer are still alive 5 years after their diagnosis, which is due mainly to the early detection and multidisciplinary treatment. The UK and USA have one of the highest incidence rate worldwide, together with the rest of North America, Australia, and New Zealand. And this map shows the areas in red with high incidence of breast cancer, where the ASR is more than 90 per 100,000. The areas in blue, where we are lucky we are in, the ASR is around 20 per 100,000. But we have to bear in mind that we don't have any early or screening program, so the real incidence rate are not really clear in our area. The WHO has suggested that two components of early detection: first, education; second, screening program. There is a special edition for our area, the Eastern Mediterranean region, our area. According to WHO, mortality estimates cancer as the 4th ranked cause of death in our region. The estimated number of new cases each year is expected to rise from 10 million in 2002 to 15 million in 2025. So we have to be ready. Of these cases occurring in the developing countries, cancer kills about 2,100 people each year in our region. In addition, the largest increase in cancer incidence among WHO region in the next 15 years is likely to be in our region, the Eastern Mediterranean region, in which projection modeling predicts an increase of between 100% and 180%. And there is a very famous study published recently from the kingdom that the burden on health resources will be very much in the coming 10 years because of the increased incidence of cancer in the Kingdom of Saudi Arabia. In May 2005, World Health Assembly adopted a resolution in cancer prevention and control, this is the number, which calls a member state to intensify action against cancer by developing and reinforcing comprehensive cancer control program. Action is urgently needed to address the growing burden of cancer in our region. This publication is mainly for our region. Priority areas for intervention and primarily prevention and early detection, particularly for breast cancer. And Saudi Arabia is part of this signed agreement. Recommendation for our region: it is important to include cancer control in the program of National Health Plan, no matter what resource restraints a country faces. A well-conceived and well-managed national cancer control program is able to lower cancer incidence and improve the lives of those having cancer. Early detection program without formal screening. The IMRA supports and endorses the promotion of public education and awareness about breast cancer in most countries, regardless of their resources. I think we don't have resources problems in our country. All what we need that we have to push and reinforce our rights of having a screening program, because I do emphasize that we don't know the real incidence of cancer in this country. And we have these offers need to occur hand in hand with the establishment of diagnosis and treatment programs. At present, resources for cancer control in our region are not only inadequate, but directed almost exclusively to treatment. This strategy, although successful, is suboptimal, as lack of earlier diagnosis reduces the value of therapy, and we all know that most of our patients, they come not only in the second stage, but more advanced stage. The impact of preventive measures on incidence is not utilized. Unfortunately, in the majority of countries of our region, as I mentioned before, they come with advanced stage. According to WHO, 40% of cancer would be avoided by means of prevention, and 40% could be cured if detected early, as in breast cancer, and the rest should be managed by palliation therapy. In case of screening of breast cancer early detection screening programs have been implemented in various countries over the last 20 to 30 years. This is not a new issue. The results tend to be fairly constant in terms of actual breast cancer detected, even though the percentage of women screened who actually present at screening with breast cancer is very low. When these percentages is multiplied by the massive number of women now participating in screening program, is resulting in a huge decrease in mortality due to breast cancer. And this is the American Cancer Society guidelines for early detection of breast cancer at age 20 to 39, clinical breast examination plus self-breast examination. They write optional. However, in our country, in a conservative country like us, we still push for self-breast examination, and because we don't have screening program, so we still insist, and we do teach the people, the ladies, how to do self-breast examination. At age of 40 and over, annual mammograms, annual clinical examination, and it's better to be done before mammography, and self-breast examination optional. I repeat, we still insist to teach them to do breast self-examination. How often should screening be done? The following guidelines are suggested. For ladies above 50 years, screening can be done every 2 years. And it is proven to reduce mortality by 26%. For ladies from 40 to 39, annual programs, annual mammogram is recommended, and it is proven to reduce mortality by 17%. For ladies below 40 years, screening is not really recommended. For ladies with high-risk high-risk ladies, I think those ladies, they should go to their doctors, so they should modify their own program, and they should tailor a program for them, how should they do their screening program. What about Saudi Arabia? We have our Saudi Cancer Registry. The Saudi Cancer Registry was established in 1992, and we have a report which is released every 3, 4, 5 years. The latest in the net is at 2007. The good thing about 2007 report that they reported the mortality rate in that report. However, I managed to get from one of our colleagues the latest report, some of the slides from the latest report 2009, and it shows that cancer is really increasing. And breast cancer number in 2009, it's really increasing. The latest number is 1309. And the percentage is around 26.4. And it is the number 1 cancer among all female, adult female cancer. The median age did not change. It's around 47 years, and it shows that it is a decade younger than the ladies in Europe, and even 2 decades younger than ladies in US. The commonest type of cancer is infiltrating ductal carcinoma. This is a very nice slide. If you compare stage 1, in US, 60% of the ladies, they present with localized disease. And this is all because of early detection, because of screening. However, only in Saudi Arabia, 13.7% of the ladies, they come with localized disease. And this is because we don't have early detection programs. So most of our ladies, they come with regional involvement, and this is affect their staging, and which reflect later on their survival. The commonest area which is involved with the cancer, the ASR, is the Eastern Province. Since 1999, it has the highest incidence, the Eastern Province, and then in 2008, it's almost 31 per 100,000, followed by Mecca al-Mukarramah, then Riyadh. We don't know, we cannot explain why this is, why there is a regional difference in the incidence. This is our rank between the international comparison, and I still insist, I don't think this is really right, because we don't have screening programs, so the incidence, we cannot say this is really a correct incidence because we don't have screening program. Our survival rates is around 65, as compared with the US, it's around 89, and this is again because we lack early detection program. What did we do in the Eastern Province? We established the Breast Cancer Early Detection Committee in 2008, and this is the names of my group, and I have Dr. Widad with me, Dr. Widad Baqutada. She's this one. I would like to thank her for all her help on the analysis. And our mission is to save women's lives by promoting prevention and early detection of breast cancer through awareness, education, and provide a reachable mammographic facility to all women. What we did in October 2008, we launched our Pink Eastern Breast Cancer Awareness Campaign. At the same time, we managed to convince the businessmen of the Eastern Province and the governor of the Eastern Province, Prince Mohammed bin Fahd, to donate the first mobile car, and it was really the first car in the Middle East to be bought by charity organization. And we started our mission in October 2009. And it was in 4 cities from the Eastern Province, which is divided to 9 big cities. This is some pictures from our campaign. We started with 900 volunteers. Next year it becomes 5 cities, and then we started 6 cities. And luckily, by our last campaign, 2012, we involved all the 9 cities of the Eastern Province. And this year we were lucky that the Aramco Saudi Aramco donated the 2nd mobile unit. So we have now 2 mobile units in the Eastern Province. And the good thing that this year also in our university, we launched our campaign in the 24 female colleges, and we involved more than 24,000 young ladies in our campaign. We distributed more than 100,000 brochures and CDs to encourage ladies to do their self-breast examination. Early detection program strategies. We insist in education and we promote mammography. And plus that, we also launched the 2 More Minutes Saved My Life campaign, which is directed toward the primary care physicians as well as the OB-GYN, because we want to secure the flow of our customer, which is the ladies, normal ladies above 40. And we want to convince the primary care physician and OB-GYN physician to refer all normal ladies to mammography, because we tell them we want to see it before you feel it. We tell them about the Sogran time, which is the time period between when the breast cancer may be detected by mammography while it is very small and before it grows big enough to become symptomatic. And we tell them that Sogran times is different. In young people, it's shorter than in older people. So we tell to teach and educate the physician. So they are our facility to educate also the patients. Our approach to education, we believe that it's the right of the women to be educated about breast diseases. We educate them. Our education is culturally appropriate, so they will not feel offended. They will accept us. And the point we always stress that breast cancer can kill you. However, if you come early to us, we can save your life. And breast cancer, not all lumps you feel in your breast is cancer. It's more than 80% of lumps are benign lesions. And the most important thing that we learn ourselves from this campaign, that people fear from the word mastectomy. They rather die with keeping their unhealthy breast than that people, they will remove their breast. And this is the important point we really tell the ladies. We will not, if you come early, you will save your breast. You will not, there are a lot of treatment options. And I learned this from the ladies in the campaign. We did that through the media, through newspaper, magazines, distributing brochures, radios, TV, and we really did it through different ways, doing lectures, going everywhere. How the ladies come to us? Usually we announce about our mobile clinics, where are we? So usually the ladies self-refer themselves to us. Usually when they come, they fill a questionnaire. If a lady has any problem or she has symptoms, we tell her to go to the hospital. We only accept people without symptoms. We have well-trained nurses where they do inspection and clinical examination, and then we conduct the examination. This is the form where our nurse, they do the examination, they localize the masses or whatever if there is a finding, and they fill the form, and this is our reporting form. And the result of the screening, if it is in the same area where I stay or in the foundation, the result will be within 1 week. If it is far away, the result they will get it. They know that they will get the result within 2 weeks. And then all abnormal results, the navigator will reach them within 2 weeks, and we will, this is the scheme of our work, the workflow. All by RAD 1 or 2, they will tell them, you are normal, you come back after 1 year. The abnormal results or recall, we'll arrange an ultrasound. If it is normal, she will go back to, we'll tell her we invite her for next year. If she has BIRAD 3, we will, for short-term interval or follow-up, or we will arrange for a biopsy if she's BIRAD 4 or more. So what is our staff? We have now 2 mobile, we have 2 well-trained nurses, we have 2 mammographers, and I do the reading. We have 2 senior specialists where we do double reading. We have 2 junior radiologists where we are training, and we have very, very important person, the physicist, where he do the quality control for our equipment. Until now, we did 4,817 ladies. And this is the distribution. First year, we did only around 1,700 patients, ladies. Next year, the number is double. And this year, like a breakthrough. That means we are really start to touch ladies. They start to trust us. Before, in the first year, 37 months ago, when we go to the ladies, they say, oh, no, we don't want to hear about cancer. Please don't open this topic with us. Now, ladies, they come to us. So I think we start to make a difference. Our recall rate, I think within the acceptable level, when we compare it with the international data, it is around 7.6%. Until now, we diagnosed 34 breast cancer, which is around 0.7%, 26 Saudi ladies and 8 non-Saudi ladies. Our median age goes very well with the national data. It's around, the median age is 47 years. The commonest type of cancer, just the same like the national data, invasive ductal carcinoma, and the commonest location was upper outer quadrant. Size of invasive cancer, the size of tumor at initial screening is very important, and we have to highlight this. It determines the seriousness of the disease and the appropriate treatment measure. The benchmark indicator for treatment size is whether or not is less than 10 millimeter in diameter, with 15 millimeter being the second important benchmark. And this is the distribution of sizes. The commonest size was less than 2 centimeter, which is 30%, followed by above 2 centimeter, which is 27%, and then more than 40% is less than 15 centimeter. Interval cancer, which is also very important. We had one case of interval cancer. She came to us in October 2010. She was completely negative. She came back after 2 years and she had a mass lesion. Breast density. This is also a very important thing for me. As a radiologist, Saudi radiologist, we always used to believe that Saudi ladies has a very dense breast. And we all know that studies constantly showed cancer risk to be 4 to 6 times higher for women with extremely dense breast than for women with low density breast. In 1967, Sir John Wolfe, a radiologist who specialized in mammography, first proposed that there was a strong association between the parenchymal pattern seen in mammography and the risk of women would later develop breast cancer. Since then, lots of studies were published about the relation of breast density and breast cancer. In Saudi Arabia, there is 2 big studies by Professor Asmat Dabbagh in 1996, which also shows the relation of that Saudi ladies had, which in her study showed that there is high incidence of high density in Saudi ladies. Myself in the Eastern Province, also we revised the more than 500 mammograms, and also we published that Saudi ladies have high breast density. But now the things is different. Why? Because me and Dr. Asma and the others who published, we were looking at mammograms for ladies who present with symptomatic mammogram, and that was the difference. So now there is something different. And we all know that mammograms, dense mammograms, makes lots of limitation in our reporting. You can miss cancer in mammograms according to other publication. And this is our finding, and this findings is under publication, but I just wanted to report it for the others to this is, I think, a good news that our ladies, most of our ladies are 77% of our ladies, they don't have dense breast. How many ladies came back for screening? In the first 2 years, only 10% came for screening. So, what are the major drawbacks from our work? The major drawbacks that relevant patient data is lost due to what? Positive breast cancer patient outside Al-Khubar area and Dammam, they are away from us, they prefer to be treated and followed up in their region or in their cities. For that, we lose follow-up from them. Also, Bayrad 3, also they are away from us, also they are followed up in their region, so we lose them. Also, we need a help from modest coordination from MOH, Ministry of Health. Coordination needs to be further to secure referral from 40 years old ladies to our screening group. Shortage of manpowers to coordinate patients, referral and documentation, and also we need more radiologists to read mammography. Also, we have cultural and socio-economic circumstances limiting the process of screening. Also, we still have false belief that radiation can cause cancer by itself, which prevents some ladies to come to us. We have lack of access to appropriate medical services. Until now, you have even long waiting list to the clinics, to the surgeon, to the specialist hospital. You have a lot of problem like this. And for non-Saudis, there is lack of health insurance. We know that breast cancer is a problem in Saudi Arabia as in the rest of the world, but in our country, there is a need for more researchers at a national level to identify the cause or the risk factors of breast cancer in our country, why the disease is increasing, and what are the reasons for marked regional differences, and do we have the problem of young age? And I think the answer is coming soon in the latest report, 2009. We have to really educate the primary care physician and the gynecologist, because they are the front line. They are the doctors who are at the front line with the ladies. And we have to increase the public awareness regarding the importance of early detection and cancer prevention. And we have to insist in implementation of screening program, as mammography is a cost-effective, highly sensitive modality with increased specificity after the age of 40, and clinical trial provide relative reduction in mortality of 30%. And we have to apply the WHO recommendation for optimum breast cancer care as screening mammography, specialized radiological center, early diagnosis of cancer. Diagnosis should be made before any surgical procedure, and patient informed should about her management option. And we have really to start multidisciplinary approach. And I do believe that the 100-mile journey starts with one step, and the dream can be true if there is a will. We are lighting a candle in the dark, and we believe that one day our dream of having a national screening program of breast cancer is coming soon. Thank you very much.
Thank you very much, Professor Fatma. Our next speaker is Professor Den Hayten from University of Amsterdam. He's CEO of Dutch National Training and Expertise Center in Nijmegen since 2005. He's a radiologist involved in screening of breast cancer since 1993, and he has a lot of research in this regard. Professor Hayten.
I try to get my presentation.
He's going to talk to us about the Dutch experience in breast cancer screening.
Okay. Well, what I'm going to show you is the experience in the Netherlands, and that's now over something like 25 years. And so where you are now, you have to see that we are now, let's say, 20 to 25 years later. And we have been giving speeches in a number of countries, and we would like to state the first thing is actually what is screening, and it's already has been hit on in the previous speakers, but for us it's very clear that screening should be not only an apparatus of shifting, of sieving. Here you see the population, here you see the population is normal population and abnormal population after one round. And this is what most of people would consider screening. The problems arise if everyone recognizes that there are still some abnormals in the so-called normal population, and there are still also normals in the abnormal population. You have to deal with that. It's more or less, you have a screened population and you have a recalled population. You don't have a diagnosis yet if you are really in screening. So that's important. But what is much more important is what we see now. The figures that you saw just here from Saudi Arabia are first round figures. And this is what you will find in the first round. You have much more pre-symptomatic disease. And you go for a first screening round and everyone is happy. And everyone is happy because you find so much breast cancer. But actually this is not where you are looking for. You're looking for the smaller tumors. So now you get the interval. In the interval, the left-ins will become symptomatic and they will be picked out, and you leave. Now you have the start of a screening system. Here you can start really early detection. And this is what you should to be continued for many, many, many years. So, what we mean about screening is screening of breast cancer. It's the most misused word in the world, screening. But we mean screening for breast cancer, mammographic, digital, organized. And organized is very strict in this sense. Some facts you already saw that, so 1.5 million women, 300 deaths annually. And here you see the Glomocan image, and it looks like a Western disease. But if you look very closely, it's the incidence is it's a Western disease, but mortality is not a Western disease. Breast cancer mortality is not specific breast for the Western countries, so it's a worldwide problem. Why were we so early in the Netherlands? Here we are. This is the incidence in Europe. It's much, much, much higher than wherever in the world. We have the highest, one of the highest incidence, somewhere around the same as Belgium and parts of the UK. So that's the reason why there was also very early interest in screening programs in the Netherlands. Most of people say, well, if you start screening, you start finding cancers, and then you have this. You have an enormous rise in incidence, but at a specific moment, it will disappear. I'm so sorry. This is what happened in the Netherlands. This is 1910 in mortality of breast cancer. And this is 1990 when we started screening. Here, at this moment, 65% 5-year survival in Saudi Arabia. When we started, it was 50% survival in the Netherlands in 1990. Here we see the age pyramid. The problem that you have depends also on the age distribution. This is the age pyramid when we started in 1975 with our screening system. And this is what's happening now. We have an elderly population, and elderly population have much more breast cancer. But these women are healthy. Screening is about health and not about disease. 80% will never see something of their tests. They only go once in a while. For 5 minutes in 2 years in the Netherlands, they go for a bus. And that's everything what's into it. Their sisters will be saved. Most of them will never have any harm about screening. So don't overexaggerate that screening does so much harm. We will grow. We do now on a yearly basis 1 million women. And it will be 1.5 million in a couple of years. So we can handle that, that's no problem. This is Saudi Arabia. It's a much more normal build-up of the country. You have a very young population. But the age distribution, as you saw just, is completely different. You should adjust your system to a younger age group. Okay, well, what was the history anyhow? The history was, it came from Germany, a person whose name Ernst Krokowski. He was very, very patient. He accounted there was an enormous relation between metastasis and the size of the tumor. And since you are all radiologists, or most of you are radiologists, that's why we are in. We are trying to find the breast cancer as early as possible. We don't do diagnostics on the axilla. We try to find the tumor as small as possible, and that saves life. Of course, you have fast-growing tumors, normal-growing tumors. I'm so sorry about this. So here we have fast-growing tumors, slow-growing tumors, but also very slow-growing tumors, but still their only opportunity is to get them as early as possible. So that's the solution. And in the Netherlands, after 71 in New York, we started in 1975 with 2 pilots, like here in Medina, and in the eastern part of the country with small pilots. We have a population screening act in the Netherlands, and you're not allowed to screen without a permit from the government. And in June 1987, the Health Council of the Netherlands said, well, mammographic screening is currently the only cost-effective screening, so it was in 1987, for breast cancer if we meet certain criteria on organization and financing. And since that time, they have been financing every year breast cancer screening. So you have to have the commitment of your government. And so we build up a screening program with a target age. In those days, normal, we should go younger now, from 50 to 75. 75 was later implemented, and screening interval of 2 years. So, small information about organization. Here you have the Ministry of Health, Welfare and Sport. It's free for the Dutch population. So they're involved, and you have here 2 independent audit and quality organizations, and the right ones are we are for the medical quality audit, the continuous, and the numbers are being done in Rotterdam by another group. We're working very close together. We're a member of each other's teams. Completely digital, independent system from hospitals, a PACS system, a nationwide PACS and information system. The only paper that we use is for information to the clients, to the women. So the target population is 2.3 million, and we do 1.2 million invitations per year. We have a lot of breast cancer patients, and they are not invited anymore in screening. So some results about the analog period. We did 14 million invitations to 3 million women, a yearly growth of 16%, attendance 80%, and the realized interval between screening was 24 to 20.5 months. Detection was, we detected over 56,000 screen-detected breast cancers in those years, of which 5,000 ductal carcinomas in situ. And 70% of the invasive carcinomas were less than 2 centimeters. This is the macro figures. Of course, we have all the figures, everything that you can imagine. We have the figures about first round, second round, etc. The lymph nodes has influence on the survival, limited, but that there is influence on the survivals. 70% of the invasive tumors was lymph node negative, a much higher rate in the subsequent rounds. The program sensitivity, which is different from mammographic sensitivity, is 70%, is over 70%, which is considered for an analog screening reasonable, normal. And for the women over 70 years, it's over 81. So this is a little bit dull perhaps for some of you, but these are performance indicators. If you try to monitor a screening system, you want to know nearly on a daily basis how things going. So how's the attendance going? In the Netherlands, the attendance is 82%. And what do I show here? I show here the first rounds in all those years. Dark blue are the people who are screened, and light blue are the people who are being invited. So approximately 20% don't comply to the screening invitation. So another point, the recall rate. Well, some people think that we are crazy in the Netherlands that we have such a low recall rate. We have a much higher recall rate for the first round. We have a recall rate of 4%, which is more or less mean in Europe. but a much, much lower recall rate in the subsequent rounds. Why is that? The reason for that is that we have a very good organization and we are very well trained. It's not necessary to recall so much to have the same detection. We have always have the prior rounds under our hands if we screen. It's a matter of organization. Detection 5.5 in those years. And you see here a result which might be of interest to you. You have to recall a lot of women more for some slight increase of detection. We do that intentionally. We ask the radiologists the last years to increase their recall. And you can see the results now. All because of the stage shift. This is the difference between a screen group and a symptomatic group. Here you see T2 plus, 60% in the symptomatic group, 70% in our screening. So this is very simple. That's why screening works, and especially for radiologists, it should be important that you realize just find those small tumors. Like here. Here we see what happened in the Netherlands the last year when we did something which I'll show you later on. We started here with real digitization. But here we started with higher recall. We came from 4.9 up to 6.0 at this moment, with a very low recall rate. Very high recall rate is not necessary. Mortality. Mortality is the only reason why you screen. And here we have a graph that now and then gives a lot of debate in the Netherlands. Why is that? That's because here we have a graph without screening, and that's been calculated by a computer program. And this is what we've been observing. So here we started screening. Here we started screening, and that's what happened. Is that proof? Well, not for all the epidemiologists, but there's quite another proof is that we started in a later moment with the age group of 70 to 75, and see what happens here. The mortality dropped enormously after we started the screening, much faster than the other group. Why is that? We were building on an existing infrastructure for the older group. So it was a sort of big bang start of screening of older women. And you see an immediately decline of the mortality here. Much, much faster than in the other group. So that's the reason why we have a very strong opinion that screening works, and it's not necessarily that you have to recall everyone. Cost. Some of you might be interested. We pay per screen €53 in 2007. We digitized the whole bunch. We had to add €4. And the quality monitoring costs is approximately €5. So this is what happened with the price. Of course, the total price of screening went up because we did more women, but the mean price per screening unit stayed stable. This is corrected for inflation. So what do we earn? Will we earn per year life saved? It's approximately €2,200 per year life saved in breast cancer screening program. Approximately the same for colonic cancer, much more for cervical cancer, and we have a limit. We look a little bit like the Scots. We don't like to spend money too much. So here you see that the Dutch limit is 20,000. What do we spend in the Netherlands to healthcare? Well, a lot of money. Now approaching 90 billion euros per year. Somewhere 25 to hospital and medical specialists. Billion. And now we're spending only 200 million on the total prevention, and we're spending 60 million in 2012. So there's 0.3 of the total budget for hospitals. So it's only a splinter with a very effective mean. You should give this information to your government because it's very effective. This is the cost of the healthcare. We should be careful that it's not becoming a disease itself. But not for screening. Screening is not very expensive. So digitization might be of interest to radiologists. It was a revolution. We do high volume screening. Was it good enough? You know, we started very early with some pilots. This is a graph I have to explain. This is the build-up of the screening of the Netherlands in the analog phase. And this is the digital. This is the digital area. This represents, with these first rounds, 1.5 million screens. And we can compare that with the analog area. It was an enormous process. So here you see the Netherlands. It's not a very large country, but we have 17 million inhabitants. And here you see a national PACS with a glass fiber connection, everything attached to everything, especially for breast cancer screening. We had to train 550 technicians and 150 radiologists, all special, dedicated training for the digitization, and a total of 1,000 people who use the system. 1,000 people who do 1 million screens per year. We have 65 mammographic units, 8 fixed locations. A fixed location has now more mammographic units than one, but we have 57 mobile units. That's a large enterprise because we do 5,000 women per day, every year, again and again, again and again. It only works if you can get the population back to the screening. The total budget for the project was 70 million. So the evaluation of this 1.5 million against the analog, the digital recall rate went up significantly, but there's a learning curve. The detection of DCIS was almost doubled, especially in younger women, which is pretty relevant. Don't believe those people who say it's only overdiagnosis. And we found significantly more invasive ductal carcinoma of the very small kind. As a result of that, significant less T2 plus, and the lymph node stayed stable, but I have to make a remark about that. It looks like that we don't influence the lymph node status, but in this period we saw the sentinel node procedure. Okay, I'm pretty close to the end, Mrs. Chairman. You see here you see the learning curve of the digital screens. Here you see the predictive value became higher, and here you see the learning curve I showed. So the general conclusion of digitization was improved screening performance, more efficiency, and a cost stable. Some remarks about the mortality decline and screening. Here we see the influence of the start of the screening and what happened here. Most of the people say, well, there's something else. Well, we have a lot of opponents in Europe, not in the Netherlands, but in Europe. Well, we analyzed that very, very closely. And this is what happened if you get everything together. before the start of the screening, if you consider the screening as one big bang, before the start of the screening, every year you saw an incline of 0.3% of mortality, and after the screening you saw a decline of 1.7. So that's pretty convincing that screening works. I'll skip this. This has to do with the influence of chemotherapy in relation to screening. The part of which can be contributed to screening is larger. It's much larger in the older population, and of course there is no real figures. If you compare women who are screened and non-screened, then the chance of dying of breast cancer for women who are not screened is 50% higher. Dus if you comply to the system, your chance of dying of breast cancer is 50% lower. This has been proven in the Netherlands, but again and again and again everywhere in the world. Last points of discussion: the Gotcha, the Cochrane. They leave out the most successful randomized trials. I don't have enough time, but I have enough time for this. There was a big row in the UK. Independent review by people who never published about breast cancer screening, and it's recently been published, the UK review, and the highlights. The highlights is significant benefit. 1,300 people prevented mortality at 70 years. Overtreatment is an offer that many women will feel worth accepting, and there's no reason to stop the program. End of discussion. Ladies and gentlemen, there are harms and there are benefits. And if you organize a screening system, you should be aware of that. And you should take the harms out as far as possible. We will skip the overdiagnosis and the false positives, but it's a problem that we can handle, especially the false positive. We're building now a system that the false positive, especially the BIRAT 0, we only recognize in screening BIRAT 0 and BIRAT 4 and 5, that the BIRAT 0 will be dealt with within 48 hours. My last conclusions: 35 years after the first pilot project and 22 years after the start of the population screening, screening in the Netherlands is a fact of life. Fear for breast cancer is diminished and not directly related to mortality. And I have to make a remark about your fear, about the recognized fear here for amputation. Most of the women don't get an amputation. 5-year survival is somewhere around 85. The 5-year survival of screen detected is near normal. The 5-year survival of screen detected tumors smaller than 15 millimeters is completely normal, is comparable to the background group. Effect on the mortality decline of the target population is significant, but it's the whole population, the screened and the non-screened, is over 30%. Figures from the Netherlands are national, very large, very detailed, and from open sources and available for everyone. And every year, at least 775, and it will grow up to 975, will prevent the deaths from screening. This is my last slide. Don't forget, 1 prevented death adds 16 years of life in the Netherlands. The system should be strictly controlled and limited cost, and a continuous monitoring, audit, and quality control is mandatory. Thank you very much for your attention.
Our last speaker in this session is Mr. Piet van Kalken. He's the manager CEO of the Dutch National Training and Expertise Center since 2007. He will talk about how to set up breast screening program.
Well, good afternoon, ladies and gentlemen. My name is Piet van Kalken. I'm the CEO of the National Expert and Training Center for Breast Cancer Screening in the Netherlands. And first of all, I want to thank the organization committee for inviting me to present the presentation Starting a Screening Program and Quality Control. I'm a colleague of the former speaker, Arten Hete, and he also told about the context of the screening. And the context of the screening and context of my presentation is that I'm also talking about the screening, breast cancer screening, mammographic breast cancer screening, and the mammographic breast cancer service program, service screening. And service screening is an organized population-based screening program. Thank you. Let's see if this works. Okay. Before starting a screening program, it's very important that you know what kind of screening program do you want. Do you want an opportunistic, hospital-based and service screening, so an opportunistic, hospital-based or a service screening? And it's important that you know what kind of screenings test do you use. In my presentation, I will point out several points for setting up a business plan for a screening organization. And I will go into the quality assurance. Before you start a screening program, there are some points of attention to make, and some of those points are from the Wilson and Junger rules. First of all, screening is justified if there's an important health problem, and if an accepted treatment for recognized disease is available. So this is very important because you have to have an important health problem to go to screening, and there must be an accepted treatment for this disease. Also, for an organized screening program, you have to reach the entire target population for call and recall. So you have to have a system that you can identify the women you are going to invite to the screening program. And the compliance of more than 50% make a program effective. And we realize it's not easy to get a compliance of more than 50%, but you have to grow and you have to believe in it. And we think after several years you can reach that percentage. And this is very important. It's important that the government has a long-term vision and commitment to the screening program. They have to support the screening program because screening is not a program for 1, 2 or 3 years. It's a program for several years, 10, 20, 30 years at least. So there has to be a long-term vision and commitment. And radiographers and radiologists should be trained for screening. Screening is not the same as hospital care. So it's important that they have a separate training for screening. There must be a system of constant quality assurance. Because you screen healthy women, it's important that they can rely on you that the quality of your screening program is as high as possible. And there must be a monitoring system of the results so you can see if your program is working. And screening is not healthcare, so it should be strictly separated from healthcare. Healthy women go to screening, and women who are concerned that they have a disease or a complaint, they go to the hospital. Population-based screening program means, according to the first report of cancer screening in the European Union, that each round of screening, the persons in the target population are individually identified and personally invited to attend to screening. So, you know your women who you're going to invite, and you can identify them so you can invite them each round. And generally, this requires a high degree of organization and population register. A population-based screening program is regional or national. An opportunistic screening is no organized screening program. We think that mammography is still the best evidence-based test for screening, and digital mammography is now standard of care. Before you thinking about setting up a screening program and make a business plan or something like that, it's important you know your epidemiology. Because it's important that you ask yourself what's the breast cancer mortality and incidence rate. And you need that to monitor the effectiveness of the program before the start. So before you start a screening program, it's important you know your mortality rate and your incidence rate. And you have to know what's the age variation in population. It's important to define the target population. And then you have to know how big is the target population and how big do you expect the participation rate will be. And this is very important to organize the program. If you, let's say, you have a target population of 100,000 women and you have a participation rate of 50% and you screen every 2 years, then you have 25,000 women who will be invited to come, will be attending to the screening program. And then you know how much mobile units you need, how many radiographers you need, how many radiologists you need, how big your packs must be. So it's important to know your epidemiology so you can organize a good screening program. Well, this is from the cancer report in 2007, already mentioned. And then you see that breast cancer is the most common cancer in Saudi Arabia. So, do you have an important health disease? Yes, you have. And 26% of the most common, of the female population cancers is 26% is breast cancer. So, you could say this is very important. You have your information, so you can start a screening program. Over here you see also from the report, it's difficult to read. This is the population, I think, 39 to 44 years. Breast cancer is the most common, and it's up to 75 years. Still the most common is breast cancer, and after that it's not the most common cancer. So this is important to decide what your age, your target population will be, and the age variation will be between 30 years and 75 years, and you have to decide to look into the numbers exactly to define the target population. Of course, when you set up a screening program, you need something like a project organization, project leader, a board, a foundation, people who are believing in the system, believing in screening, and they have a lot of energy and motivation to set up a good screening program. And you set your goals within how many years you want to set up and implement a good screening program, because it takes years. In Holland, in Netherlands, it took several years to roll out the whole screening program. And in that period, it's important that you have finance for the project, because otherwise the projects will stop because of lack of finance. And this is very important, the commitment of the stakeholders. And it means that, first of all, the government has to support a long-term screening program. That's important. And you have to have something like a public registry, or to invite women every 2 rounds to the screening program. And if you don't have a good public registry, perhaps you can use the information from the health insurance companies or other systems in your country who have a lot of information where women live and how you can reach them. But it's always difficult to get women to the screening program. They have to have a mindset that something new like screening in a country can save lives. Very important is the support of the hospital, because when a woman gets referred from screening to the hospital, it's important that within a few days women can attend to the hospital for treatment. In the Netherlands, we have sometimes that women would have to wait for 6 weeks, and it's terrible. We get very angry when we hear that. And also we think it's very important to convince the family doctors or the GPs that screening is good for women, so that they can talk to women, they can advise women to participate in the screening program. Then you have the primary process. You have to decide, are you going to use double-blind reading? And how are you going to set up a screening unit? You have to make a choice for a mammographic system. There are a lot of good systems, but there are also very bad systems. And you have to make a choice for a workstation and a PACS. And it's important, and I saw in one of the slides of Dr. Tomeyer, that there's also that you describe your process. This is an example of a process, but this gives you the opportunity to organize each step and to describe each step. Okay, when a woman is invited, what's the first step? She will attend or she will not attend. Okay, what do we have to do if they're not attending? In the Netherlands, you get a new letter, a new invitation if you're not attending to screening. So it's an example where you can decide how you set up your screening program, how to describe it, and to organize each step. And also you have to make a choice, are we going to work with a fixed unit or a mobile unit, or both? Do we have the staff to examine the screening? Are they available, and do they have the right quality? Is there enough finance to do screening for more than 10, 20 years? And very important is the ICT. Do we have a good PACS? Do we have a good workstation? Do we have a digital workflow? Some examples. We helped to set up a screening program on the island of Curaçao. It's between North and South America, and it's a former Dutch island. And they chose to have a fixed unit, only a fixed unit, because it's a small island and all the women are able to come to the fixed unit. So this was the best solution. We also work with a hospital area in Brazil, and you can see these are different roads. They have to have a very good truck to go to all the small places in the middle of their region, and that's different from Holland, where we have good roads, we don't have any mountains, and we don't have a desert, and we have a lot of mobile trucks, and they are mostly about, I think, 1 or 2 months in one place. You don't see any truck, it's only the unit, and then once in every 2 months a driver will come with his truck and transport this mobile unit. And I was very happy that yesterday I saw your own mobile truck of Medina in the front of this hotel. So you have already made a decision to use mobile units next to a fixed unit. Most important is culture, but we think as a National Expert and Training Center that the level of quality can be the same all over the world. The level of quality of equipment, the level of quality of radiographers, and the level of quality of radiologists can be the same all over the world. We can learn from each other and we can make this level as high as possible. But how to communicate with women and staff depends on the culture of your country. So you can't copy the Dutch way of screening to Saudi Arabia. It's very important you notice your own culture aspects. So we believe that trainers and teachers must be part of the culture of the country. And you have to use the teach the teacher of train the trainer situation. And we are very happy to help you with that. The communication and information is very important because it's all about the awareness of women. It's about early detection, and women have to know that. And it's very important how you invite women and how you tell them about the results. It's very important to give them the right information about screening. Not only the benefits, but also the harms, but in the right balance. And communication with family doctors, screening and hospital is very important, especially for the follow-up. So a hospital has to know, okay, we have a screening program, so that means that there will be some women referred to the hospital and we are ready to take care of them. Quality assurance. A breast cancer screening program demands the best possible quality of equipment and staff. That's our goal. We think this is important. If you have a screening program, if you screen healthy women, they have to rely on the best quality you can provide. So you could say there's some kind of chain of quality. The equipment is important and has to be perfect, but only if radiographers perform well, radiologists can perform well. So if there is an artifact in the equipment, the radiologist will refer because he sees an abnormality in the image. But if the positioning of the radiographer is wrong and there's a fault or the breast is not fully shown, the radiologist also will refer because there has to be further examination before they can decide what to do. So it's a kind of chain of quality: equipment, radiographers and radiologists. A quality system is, we think it's about guidelines. You need guidelines because you want to measure your quality. Are we doing the right things in the right way? But also you have to have a quality assurance by teaching your staff, testing the equipment and auditing the staff. And by auditing the staff, we don't mean auditing the procedures, but we mean auditing the performance of your staff. And also, a quality system has to look forward, so you want to optimize your quality by feedback, monitoring and evaluation, innovation, sometimes from the vendors, sometimes from doctors, and scientific research. It's important to make your program better. Guidelines, of course, they're made by cancer societies, and they are guidelines for equipment, for radiographers and radiologists. And in Europe, we have the guidelines for the breast cancer screening programs, and we now have number 4, and we are working on the 5th edition of the guidelines for breast cancer screening. And our organization is participate in the writing the 5th edition of the guidelines. Those guidelines are important for your uniformity. So all the radiographers work in the same way, make an image in the same way, and all the radiologists do their reading in the same way. So that's important so you can reproduce your reading. So every 2 years the mammograms look the same and you can, as a radiologist, easily compare the rounds. Our organization in the Netherlands is responsible for the physical, technical quality assurance. And that means that we do type testing of new mammographic systems. And only if we say it's good for screening then the screening organizations can buy that machine and use it for screening. And if they buy a machine and they install it, then we come over and do an acceptance test. And after that, they are allowed to go screening. And in the screening process, we do weekly tests, half-year tests. And because it considers a lot of information, we choose to have KnowledgeNet on our website so people can read about what the test is about. But also you can read which machine is approved. For radiographers, we do the same. Every radiographer who works in the screening program in the Netherlands has had an education in our center. And we do quality audits every 3 years with radiographers. And then we look at the images they made. Is the positioning good? Did they perform well? And here you see pictures of training in Curaçao and in Brazil. And it's important that we also have KnowledgeNet for radiographers so they can read on the internet how to make a special mammogram or what kind of procedures there are. It's all the same for the radiologist. We have a training center and you see a lot of radiologists behind the workstation, and this is one of our members of the LSCB, and he is giving advice how to read mammograms. Every radiologist have to have an education in our center before they are allowed to read mammograms in the screening program. We also do the quality audits with all the radiologists in the screening program. And with them, we look at all the interval cancers. We look at all the cases they referred, and did they perform well? It's a very tense situation because they have to be open in their work and they get feedback on their work. And also for them, we have KnowledgeNet, so they can read a lot of the procedures or the tips or the advices we can give them. I've been asked to tell something about our organization and what we have planned. Each year we have a training, digital breast cancer screening for radiologists, and it's an international training in the first week of June. And it's a very individual training for 10 radiologists from all over the world. It's very popular. Each year we are very successful and fully booked out. So for this year's, the first week of June, there's still some places left for an international training. We also developed a European course of breast cancer screening for radiologists with a diploma. And we were asked by the European Society of Breast Imaging to set up such a course, and they want to have a diploma for European radiologists who are screening in centers in Europe, so that there is a uniform diploma and a degree. And the latest thing we did, we developed a self-test for radiologists and for radiographers. So it's a test with 60 cases where the radiologist has to score in which place there's an abnormality and how they define that abnormality. And then they can see for themselves if they are a good or less good radiologist. We developed also some posters about positioning for radiographers. In the Netherlands, each screening unit has this poster in the exam room, so radiographers can see, okay, how do I have to make this kind of image? It's fairly clearly explained with some drawings, and we are also getting a book about positioning also in English this year. In conclusion, I'm almost ready. A well-organized screening program is a long-term program to to guarantee continuity. It's important. It's not for a few years, it's a long-term program. Uniform quality of equipment, radiographers and radiologists must be guaranteed. And screening must be organized within the specific culture of the country. The effect of screening, of a screening program, must be visible. So you have to have registration, monitoring and evaluation so you can measure the performance of your screening program. We think that quality counts. Thank you very much.
Thank you very much for all the speakers. Now the floor is open for questions, and I invite all the speakers to the stage, please. Any questions? Can we switch the light on, please?
Yeah. Well, I don't know about lung cancer, but for the Netherlands, I think it's important. We've been starting the screening program in 1975, 1980. So then, and we have in the Netherlands a culture when you are invited by the government to come to a screening program, you go. So it's about culture also. So I can't say, well, this is the best way to do it in every country, because it's not. And we have also have a time difference, because we're now 25, almost 30 years further. So I think it's very wise to look at your culture and what is important for women or for families to so you can address them. And first you have to reach them, so you have to something like a register. Then you have to persuade them to come to the screening and to come back. So it's very important to communicate with them within your culture. We have experience in Curaçao. Letters are not important in Curaçao. Radio is important, so they listen to the radio. So they try to convince women to come to the screening program because they spend a lot of time on that and on the radio. In Brazil, they organize parties for women where they can do their nails and their hair, and they have cola and cake. Yeah, and that's their culture, and they're for a whole day. They wait on the central place in the city, and by the way, they do a mammogram. So it's all about culture, but it's something you have to work on very hard. And when the number of participation is changing in the Netherlands, we get very nervous. So we got to do research why it's growing or why is it increasing.
What's the reaction of the public when every 6 months there is a report saying, okay, mammography is good, mammography is not that good enough, and we have conflicting messages to the public that this is useful or it's not. Again, this is the same thing as the other smoking. The good thing with prevention as far as cigarette smoking, that again, people are high risk, we not be able with them, try to control them.
No.
Is it, are you meaning the discussion, the scientific discussion about the efficacy of screening programs?
That's correct.
Yeah, we think it has some impact on the woman, but not very much. When there is a program on the television or in a newspaper, we hardly see any effect. We are a little bit afraid there will be gradually some effects, but until now there's hardly any effect. They consider it as a discussion in between scientists, and most of the people has the the feeling that that early detection would be a model that is okay. But still, it might be disturbed by the ongoing debate, the eternal debate about the harms and the benefits of the screening. So when you start screening, it's very difficult to be completely open and, about the disadvantages, because the woman will have the impression that they have a real chance of being harmed by the screening, but there's so much, it's so little chance. But still, that's the problem. And in the beginning, and that was also the criticism, that the harms were, let's say, left out for the information to the public. Now, in 2012, that would be impossible. In those days, it was because of compliance, it was left out.
In fact, answering about this debate, we call them the anti-screening people. They issued a lot of papers antagonizing the importance of screening, and then 70 of the eminent breast radiologists, they answered scientifically on that, and they analyzed their papers. And we can find the answers if you search for that. Actually discuss it in the RSNA this year, exactly this topic. From my side, I saw two good examples of the screening programs in our country, which is in the Eastern region and in Medina. And we started something small experience in Jeddah, and we have another experience in Riyadh. But I wanted to unify the inclusion, the selection criteria, which is not the same in all the programs. For example, regarding the age, and the screening interval, it's different. We see it 1 year and 2 years, and we have to unify that. And also, for every program, we have to see clearly the performance indicators in order to audit your program. For example, what is the target population in Medina area, which is according to the selected age. So you are selecting from 40 and above or 35 and above?
Actually, we select from 35 years old and above. I mentioned that our targeted group more than 300,000 ladies.
In this target age group,
Yes.
35 and above is
Yes,
3,000?
Yes, more than 300,000.
More than 300,000. So what is the uptake of your program? You are targeting to finish this over how many years? Over 1 year, over 2 years, in order to calculate the uptake of the program?
Yes. Actually, I count that if we did about 1,000 per year, we will need 30 years to reach our target. Because you know that if we did 1,000 cases per year, we will need 30 years. But if we did up to 10,000 cases per year, we will reach it in 10 years or more.
But again, this is the demographics Mr. Kalkin was talking about, that you have to know what's the number you want to screen, and in order to order how many equipments you need, how many radiologists. I don't think it's practical that I screen my population over 10 years. So when I will do the second round.
Yes, because actually this number, which I mentioned in my presentation, it is just for people who are living in Al-Medina itself, not including the people who are in the rural area. Because in the remote area, we are still, our mobile track doesn't come out of the Medina.
So this 300,000 is Medina city or Medina region?
No, this total population in Medina region. Our target is more than 300,000 in Medina region. But our experience just included in my presentation the number which for the ladies who are living in Medina itself.
Yeah. And also, this figure is very important, Dr. Muslih, that the detection rate in the Medina over the past few years, it's 1.6%, while it's in Eastern region, it's around 0.7, correct me Fatma if I'm wrong. And in our limited experience, we did it for like the last year, it's 0.56%, and in Riyadh, it's 1.3%. So the highest detection rate is in your region. So you have to focus more and to increase the efforts, maybe more radiologists, more units, whether mobile and fixed units. So it's a real problem in Medina. which is surprising. The figures were surprising to us.
Yes.
Yeah, but there is a point, we should knock for the reasons.
Yeah.
First, are you admitting all ladies, everybody, symptomatic ladies are going
No,
there?
no. We are having separate. We are having screening center separate for asymptomatic
طيب,
ladies.
you did
Because
not show us, 1 minute, you did not show us your results, what is the size of your tumors, because I cannot believe it in a small area your incidence is that
No, it is
incidence.
more, even more, because symptomatic lady come to our MAMO unit directly from King Fahd Hospital. During the last 3 years, when we established our MAMO unit in King Fahd Hospital, we discovered 200
And these
case.
are all Saudis?
Saudi and non-Saudi. And I have, yes.
1 minute. This is very, very, very dangerous statement. Before we are breaking this news to the media, this is very dangerous because this number is really a big number and very dangerous number. Please, we have to be very careful.
Yes,
And,
it is like this.
1 point something is
1.67.
Yeah, it's
The
like in
yes.
Riyadh. Riyadh is 1.3%.
Yeah,
So
but
among
we have
only-
to, we have
yes.
to be careful to first to differentiate. This is even in Riyadh. We have to address these questions. These patients are purely asymptomatic
Yes.
because lots of patients they say it happens to us. The patients to bypass the hospitals, they say no, we don't have and. They come to us and when they come with masses above 5 centimeters. It cannot be that they are asymptomatics. Even if they lie, we are doctor, we know it. Number 1. Number 2, we have non-Saudis. We have to differentiate. This is statistics. You have to separate your statistics. Saudis from non-Saudis because this will reflect in your statistics. Now you are saying
Yes.
these statistics, some Saudis, some non-Saudis. So we should not rush because we are just growing. And the third and last thing for me to say, we don't have the right to say we are screening. We are a charity organization just starting. Screening is not our job. Screening is the government job and it is the Ministry of Health. As I mentioned, we are just doing an experience. We are showing that we are as radiologists, we are ready to help you, government. We are going to help you, Ministry of Health. We are willing to do something. We are here, but we should not say we are doing the screening for you. No, this is their mission because we don't have the epidemiology. We don't have the numbers. We cannot force the people to come again. This is another drawback in I did the first round. They don't come back. Because we need something like Sahar. You should force them to come back for the second screening. So we have to be, I think, this is internally, we show them our experience. We are willing, we can do it. We have all the power, we have the manpower, and we have the equipment. The kingdom even have the money, but we need the will. And we have statistics.
Yes.
But breaking numbers like this, I think we should hold our horses.
Professor
I don't-
Okay,
Hayton?
Doctora.
Professor
we need
Hayton?
wise people like Dr. Muslah to comment.
I think if you allow me, Dr. Iman, what we're doing in Medina is just the beginning of screening. And we are a charity organization, and we have our limitation resources. When we start the screening, we have no facilities in MOH Medina for biopsy. So hand in hand, we started the unit in King Fahd. And I think what we did is that we gave a good message to the ministry that this is their duty. And that's why when we get the mobile unit, we gave the whole responsibility to the preventive medicine, the non-communicable disease branch. And they realized that this is their own job. Now we have some visitor from Ministry Riyadh to see the experience here, and I think they're in the process of making a national program.
Excellent.
So far they got 4 units, mobile units in Riyadh, MOH, but unfortunately they're not able to work on them yet. They don't have enough radiologists or enough technician or enough resources. But I think the message is clear that we are charity. We are starting very simple, according to our limitations, and eventually I'm sure Ministry of Health will take over, and they will do the 10,000 in maybe 1 year
And
or
we
2
will help
years.
them
Yes.
also.
Well, I congratulations, Dr. Masleh. With this limited effort, your detection rate is very high. When you have full support, what will happen?
I think what we did is we trained our radiologists very well from day one,
Yes.
Excellent.
because we saw the other experience and we found out that there are limitations, and that's why we had to have little number of cases or screening patients so that we can get better results with the help of Dr. Ayman and everybody from Riyadh. You know. The
So my
process
little
from the
advice,
beginning.
please, after 4 years, you have to give us some results. Even if it's not published in journals, when you have presentations like that, you want figures, clear figures for all the indicators.
Doctora, we included the طيبة universities, the biostatistics people, and the community medicine,
Excellent.
and they have a program actually to work up on all our statistics. Unfortunately, the system we have was not built correctly for statistics, so there was a lot of limitations for the data. That's why we don't have
Even
good
with us,
data. Yeah.
عشان كده
Yeah.
we are a charity organization, we have
Yeah.
our limitation. بس إنه I think we are showing the Ministry of Health
Yeah.
إنه there is a will. We are willing to do something. يعني بس we need the
Yeah.
help of Ministry.
What
of
we
Health.
say, it's a humble, just starting experience, and hopefully
Plus,
in the
there is a
future-
real problem.
There is a problem, yeah.
Professor Hayton?
You should not forget that this is mainly a first round effect. So most of the women you see are there for the first time. So they won't be really symptomatic, but there's some sort of subsymptomatic. I show that that's very important. You can screen, you can do early detection without cleaning your population. It sounds very, very bad, but you have to clean the population first before you can go for a thorough full screening system. So, and then you have the statistic noise. You should join your figures in Saudi Arabia and have more figures. Then you can do something with statistics.
I have a
join.
question to Professor Hayton and Mr. Kalkin. When we talk about the interval cancer, incidence of interval cancer, this means we have to do all the clients again for the second round in order to calculate. But if they're not coming, they're not showing up like 50%, so I cannot calculate the interval cancer rate, right?
You have to connect the national cancer figures with your screening system. And you have to know the breast cancer cases which being found in hospitals, and you have to match this with your screening system. And so, but it will take many years often, but it will be better and better and better with digitization. But that's the way we do it. We just connect the screening information system with the cancer information system of the Dutch Cancer Society. So you should have some national information system about malignancies.
And also you mentioned in your presentation that you instructed the radiologist after a while to increase the recall rate in order to get a smaller stage of cancer. And
Yes.
what's the limit of the allowed recall rate?
Well, we did extensive research on recall, and I can give you an hour lecture about that. But we think that 2% for the Netherlands will be okay. It will be a little bit higher, 2.5, 3% on the whole. In the first round, we go up to 4 or 5%. In the subsequent rounds, we go. But we came from 1. And that was too low. And when we started, we say, well, okay, get up with screening. So we went to them and asked them to adjust their screening system, and they did. But there's no doubt. If you ask a radiologist, just be a little bit more sharp, but not too much. Then he will do it. And in the Netherlands, they will do it. We don't have this we don't have this medical legal problem. You know, not every woman who is missed isn't too big, will go to the law, to a judge. They won't sue us. They know that this is screening, and screening is not perfect.
Yeah.
So that's so we, because we have a relative small group of 150 radiologists. We all know them. We can steer them a little bit. Of course, they are normal radiologists like you and myself, but we can say, okay, we did extensive research on this. In 2%, if you want to avoid one interval carcinoma, if you go much higher than 2%, you will have to make 282 false positives. This is the balance that you have to seek. This is overcalling, we think. So the optimal area is somewhere between 2 and 3 for the subsequent rounds.
Yeah.
First round is a different question.
I have just one last question. So, to gauge the success program of a screening program, we emphasize a lot about the detection rate. But do you have enough time now to really look at the cure rate? I mean, you talked a little bit about the decrease of death rate, but do you have enough lead time bias, I guess, to see whether there is enough, you can gauge actually the success based on the cure rate?
Yes, but we of course we know that that lead time bias is of course a problem. But if you are working already for more than 20 years, that's not a problem anymore. So we know exactly what happens with the screen detected woman. They will hardly die from breast cancer. My own sister, she was detected by the screening, and I said, well, congratulations. The one reason you're not going to die from is from breast cancer. You know, that's the reason. She was 72, and she had a 4 millimeter invasive breast carcinoma. It's not a white dove. This is normal practice in the Netherlands. We don't see very much large tumors, and if there's one, it's a very fast growing. It's a nasty one. We will never save those women.
Those usually are younger patients.
Yeah.
Yes, most of them. Yes, most of them. Absolutely. Yeah.
Any more questions? Yes. Can we have microphone here, please?
My question to Professor Hayton. Thank you very much for your presentation and also answering your question. My question regarding the high-risk population, we consider for patients with BRCA1 and BRCA2, and also with patients who had previous irradiation, what is the recommended tool for screening for such patient? And the second part of the question, who should follow this patient? Radiologist, the screening program, or who is?
In the Netherlands, the guidelines are very clear. You start at 35 with yearly mammography, MR, physical examination, and ultrasound. The chance of having a false positive is 100% in your lifetime, but they accept that, and they are being followed up by the medical oncologist. But of course, in the Netherlands, and that is what you're going to see also here in Saudi Arabia, when you start screening on a large scale, surgeons and radiologists and pathologists has to work together. And immediately the standard of care goes up. I'm so sorry about the surgeons. I don't know if there is any surgeon here around, but the standard of care, because it becomes multidisciplinary, that's the effect of screening. It's a side effect, I know, but they have to work together. So they have multidisciplinary teams. I saw in your department
Yes.
A special room for that is in every hospital in the Netherlands obligatory. You don't comply to the guidelines if you don't have a multidisciplinary room, if you don't have a weekly multidisciplinary room. So it's of course a surgeon, or a medical oncologist, to go to your question, that's the one who does the direct contact, or a nurse. Nowadays we have nurses, dedicated nurses. And it's all discussed in between in the multidisciplinary team.
So there is no rule for MRI breast for patient with high risk?
Yes, absolutely. Yes, 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 yes. Everyone.
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 And how frequent patient had?
Once a year.
So usually they do interval between MRI and mammogram every 6 months. So every 6 months, the first you screen with MRI, after 6 months with mammogram, after another 6 months with MRI. So between the MRIs is 1 year, and between the mammos it's 1 year. And in fact, the patient or the client is under surveillance every 6 months with different modality. Since no more questions, I think we conclude the session. Thank you very much for the speakers. Thank you very much, everybody.
Thank you for your discussion, yes.
Thank you, Mr. Chairman.
Mm-hmm.